half hour to hear from Janida and her stories and everything that she wants to share. And then after that, we'll ask questions and be able to have a discussion. So, send it over to Janida. Thank you.
Thank you. Thank you, everyone, for being here on a Saturday and for still showing up, even though, probably some of you at least want to be out running around your neighborhood screaming like my neighborhood sounds like right now. So if you hear the screaming or the fireworks, don't be alarmed. I just live in Salt Lake City. I'm going to share my screen with you, hopefully. There we go. And we can go ahead and get started. Maybe. Can you guys still see that? Just give me a thumbs up, Mike. Thank you. Wonderful. All right. Well, yeah, so thank you for that lovely introduction. My name is Janida Emerson, and I'm thrilled to be here with you guys this morning to talk to you a little bit more about 4th Street Clinic and who we are and what we do. So our mission at 4th Street Clinic is to help Utahns experiencing homelessness improve their health and quality of life by providing high-quality healthcare services and support services. For us at the clinic, that really means that we're taking a holistic approach to the individual and trying to provide that person-centered care. We think of ourselves as a medical home for our patients, which means we're able to help coordinate all of their interactions with the healthcare system, which can be so incredibly complicated. And we really believe in being able to offer as much on site as we possibly can. So we have behavioral health services, which include substance use disorders and mental health, dental, pharmacy, case management, and of course, primary care. A little bit about us and what we looked like in 2019. Our patient demographics, we served just over 5,100 unique patients in 2019. Most of the patients we see, about 49%, fall into that age range between 18 and 44. We have a high percentage of the individuals that we see at clinic who are uninsured or don't have access to affordable health insurance. 35% suffer from a chronic disease, and 43% are living in shelters. The other folks that we see are oftentimes living on the streets. They might be living in their cars or doubling up with other family members. But the majority of who we see, over 90% typically who we see, are individuals who are experiencing homelessness. So the question that was posed to me was to think about what my ideal would look like in terms of homelessness and the services that we provide at 4th Street Clinic and the population we work with. And so obviously that question, the answer to that question for me would be that there would be no homelessness. But I didn't think that I could probably talk about that for 15 minutes. So we're going to talk a little bit about some of the underlying causes of homelessness and talk about some of the things that are available in the system to help address some of those barriers and some of the challenges of becoming homelessness, and then spend the last part kind of talking more specifically about 4th Street and what we do with regards to that. So there are lots of reasons why an individual can become homeless, and there are lots of underlying things that might drive that. For me, the things that I want to focus on today would be on housing, stigma, and then of course access to affordable health care, which we really feel is really critical to an individual being able to stabilize and maintain that housing. So the first thing I want to talk about is affordable housing. We define affordable housing as any housing where the gross monthly cost of the housing, so that would be your rent, is equal to or less than 30% of what an individual's gross monthly income is. So in Utah, our median income is around $3,200 a month, which means that at about 30%, an individual can afford up to around $900 a month in rent. The state median rent is around $887 a month. So you can see that we're really starting to creep up towards that definition of what affordable housing would look like. And that's for individuals who are earning the median income. So for any individual that's at 50% or less than the median income, it really becomes quite a challenge at that point to access affordable housing and to be able to maintain that housing stability. The estimate for the shortfall of affordable housing in the state of Utah is 40,000 units. And of that, they estimate that about over 7,500 of those are in Salt Lake City. So I think it's really important to think about housing in the context of homelessness and stability, because for an individual, for example, who has diabetes, if they don't have a home, they don't have anywhere to store that insulin, they don't have a refrigerator, they don't have the ability to help manage that chronic disease, it becomes very challenging for that. And so it really just exacerbates, that lack of housing can really exacerbate some of those chronic diseases, which then we know have cascading effects on the individual's ability to maintain employment and do various other things in the community. So we do have some tools available to us to help with affordable housing. The most common are housing vouchers. We have Section 8 housing vouchers that are available for individuals and other voucher programs. The goal of a voucher program really is to help offset the cost of low rent for, or the rent for low-income individuals. So essentially, what a Section 8 voucher will do is if your rent is set at $900 a month, but an individual can only afford to pay $300 a month, the Section 8 voucher will make up that gap. There are other voucher programs that are out there as well. Section 8 is probably the most well-known. The challenge with Section 8 vouchers are, of course, availability. Individuals can wait for years on the Section 8 voucher waiting list before they're able to access that voucher. And then once they have the voucher, they actually have to find a landlord who's willing to rent to them with a voucher. And that can be incredibly challenging as well. And so oftentimes people look for months and months after they get their Section 8 voucher in order to find a place where they're willing to accept that. Landlord programs are another great way to incentivize affordable housing. It helps cultivate relationships with landlords, setting up funds that can offset damages and aid with down payments. There are lots of various things that you can do to kind of incentivize landlords to want to work with vouchers or to want to work with individuals who are transitioning out of homelessness. The city has a couple of those in place here, and there are lots of other models in other states where those things have been very successful. Tax credits are also a great way to incentivize affordable housing units. They're typically geared more at new development projects and most commonly come in the form of developers applying for tax credits, and the tax credits help offset the cost of the project, and in exchange for that, developers agree to set aside a certain number of units where the rent is controlled at a lower rate, so more at that median affordable rate that we talked about just a minute ago. Tax credits can work very, very well. One of the nice things about those types of units is that it starts to blend populations, right? So you have lower income populations starting to live with a different group of individuals, which we know can have a positive influence on everybody all around, but particularly on those individuals who are low income. Tax credits are really largely based off of state, city, town, like policies that are set by the state and by the city. And so it's not always the case that a city wants to incentivize those affordable units. And so more tax credits can be set aside to incentivize that as cities start to develop. And that's really been a point of contention here, I think, in Salt Lake City, as we've seen a lot of development and a lot of new condos and buildings going into place, is what that ratio of affordable units looks like, and how the city can kind of incentivize developers moving in that direction with tax credits. But we have had a couple of new projects stand up here in the last year that focus on having some of that affordable units set aside. So I think we're making some progress in that area. And then the last one that I want to talk about is permanent supportive housing. This is housing that's typically set aside for individuals who are homeless, and it oftentimes can includes lots of other services on site. So they'll have case management services on site, potentially some behavioral health, oftentimes meals, and various types of group activities can all be found on site as well. In Utah, we've really focused our permanent supporting housing efforts on individuals who meet that chronic homeless status. And so that would be an individual who has been homeless for 12 months consecutively, or for a combination of 12 months over a 2-year period. So it's a relatively small percentage of who we see right now in the homeless community, but that's really where our permanent supportive housing efforts have been focused. That's all I had to say about permanent supportive housing. So stigma, this is a really big one for me. We work with a lot of individuals who experience mental health disorders, substance use disorders, as well as have been homeless for a number of years. And so some of the common things that we see around individuals with stigma is that, you know, a lot of people feel like once you're homeless, you're going to stay homeless forever, when in fact what we know is that group of people that we just talked about in that chronic homeless definition, that accounts for less than 1% of the individuals who are homeless. The vast majority of families and individuals who come into emergency shelter and exit that shelter are doing so within 30 days. And so what we've really tried to work on here in Salt Lake is having that shelter system set up to be really focused on housing and how we can get individuals back and out of the shelter, because we do know that outcomes go down the longer an individual stays in emergency shelter. We also hear a lot that it's your fault if you're homeless, right? You must want to be homeless. There's a lot of blame around that situation, when the reality of it is that being homeless is kind of a snowball effect, and there is a huge amount of stress and fear and chaos that comes along with being homeless. And many of the causes of homelessness are barriers to being able to exit homelessness. So an individual who has an untreated mental illness is going to really struggle to transition out of homelessness if they aren't engaged in the right services. And a lot of that gets into having access to affordable health care. We also know that there are lots of diverse reasons for an individual to become homeless: bankruptcy, divorce, other unique reasons, like a pandemic, for example. We're seeing increases in those who are coming in first time seeking shelter as a result of the pandemic and what's happened with the economy. And those are all things that, you know, people can't really control, and are all underlying contributing factors to homelessness. So I like to talk about stigma because I think stigma is one of the things that makes it most challenging for an individual to transition out of homelessness. So one of the things it does is it really allows us to normalize something and put it in a box and kind of set it aside and be like, well, it's not my problem. They're homeless. That's just going to be over there. I don't want to think about that. I don't want to deal with that. They must want to be that way. And I think that really enables us to then not have to talk about solutions or things that the system needs to do or change in order to start to address some of those things. It also makes it really difficult for somebody who's right on the verge of homelessness to actually seek services and ask for help, because there's so much shame and embarrassment surrounded with being homeless. And what we know is that if we can intervene earlier in almost all situations, that typically the outcome is better for the individual and the family. So we really want to be able to work with people before they lose their housing, so that we can help stabilize them in that existing housing. Once an individual becomes evicted from a housing unit, it becomes a lot more challenging to get them back into housing, because that eviction makes it really hard for a landlord to want to rent to an individual. And it makes it really difficult to transition out of homelessness as well. It's harder to get a job. It's more difficult to have a landlord who's willing to work with you. So a lot of the shame and embarrassment around that can be really damaging. And then I think we would be remiss if we didn't talk about stigma and fear. So there's a lot of fear surrounding individuals who are homeless and people believing that they're dangerous. A lot of them do have undiagnosed or untreated mental illnesses, and so they do oftentimes appear to be having a conversation with themselves or doing something that, you know, might look intimidating from the outside, but is just a part of the disease. They actually, it's a sidebar, but my son plays violin, and we were doing lessons, and of course we're doing lessons outside in masks because of the pandemic, and a homeless gentleman kind of came walking up the street, and he was talking to himself, and you know, my son's 7, so he said hi, thinking that he was talking to him, and he kind of crossed over the street and said a couple of things and moved on. And as we were driving home, he said to me, he said, "Mommy, who is that man talking to?" I said, "Well, sometimes people are just sick in their head, and they see and they hear things that the rest of us can't see." He was a little bit thrown off by it, as a 7-year-old would be. But I think having that ability to kind of talk through it with him and say, you know, he's just sick, he doesn't understand, it's not something that you need to be scared by. Those are all skills that we need to be able to use and think about when we're interacting with individuals who are homeless. What we know is that actually individuals who are homeless are actually more likely to be the victim of a crime than they are to be the perpetrator of a crime. Individuals with a mental illness are 4 times more likely to be the victim of a violent crime than than they are to be the perpetrator of that. And so I think all of that factors into how we interact with the population, what we're willing to do in terms of working with the population, and what are the solutions. So I always like to talk about it because I think understanding those systemic issues and barriers really helps us start to think about how we can problem solve and start to humanize those individuals that we're working with. So this is where I'm going to spend the bulk of my time talking. Obviously, we're a healthcare provider. I love to talk about healthcare. You guys all heard my bio. We really do at 4th Street believe that healthcare is that pathway to stability, and a lack of healthcare can really have a dire impact on an individual. We know that lack of affordable healthcare causes bankruptcy. We know that individuals who are on Medicaid have lower rates of bankruptcy that are caused due to healthcare reasons. They tend to do better. They have less debt. And so all of this kind of wraps itself up into some of the causes that drive homelessness and what makes it so important to have healthcare. So I'm going to talk about healthcare in the context of adverse childhood events, and these are oftentimes referred to as ACEs. So the Adverse Childhood Event Study, it was initially done at Kaiser Permanente, and the first study was conducted between 1995 and 1997. It started with a physician who started to notice there were some similarities in some of his patients who had similar health conditions and had poorer outcomes than some of those other patients with the same conditions. And he started to get curious about sort of what were the things that had happened in an individual's past, to try and get a better understanding as to what was going on with them in that moment as an adult in his office. So the first study looked at 17,000 patients and asked a series of questions about childhood events. 1 point was given for each factor that had been present for an individual in their childhood. And then they looked at those factors and how it impacted individuals over their lifespan, particularly related to chronic disease and healthcare outcomes. They kind of narrowed it down to these 10 categories that you're looking at here. And this has sort of become part of what the ACE screening tool looks for. So it looks for aspects of abuse in a childhood, physical, emotional, or sexual, aspects of neglect, which would include physical and emotional, and then household dysfunction. So did you live with an individual with a chronic mental illness? Did you live with an individual who had was incarcerated or had some sort of relationship with the criminal justice system? Did you witness your mother being treated violently? Did you live in a household where there was substance abuse, or did you live in a household where there was divorce? And so I think it's really important to caution or to preface when we talk about ACEs that, one, just because one of these things may be something that you yourself could check off or another individual could check off, doesn't mean you're going to necessarily have a poor health outcome. And two, the vast majority of the population has at least one ACE, if not more. But what they found as they looked at individuals who did have ACEs was that they had some pretty dramatic differences between the general population and individuals with more ACEs. So they developed the ACE pyramid, and you can start to see as you stack that pyramid up how those experiences really can create that trajectory for individuals that would result in a poorer health outcome. So I just want to kind of walk you through what that might look like for an individual. So I want you all to picture little Johnny. And little Johnny was born into a home where there is a family member who's transitioning in and out of prison. He is a parent with an SUD disorder and an underlying mental health condition that's not being addressed. Lots of strangers are coming and going into his home as he's growing up because of the substance use disorder that's going on. And some of those individuals who transition through the home at various points can be abusive. So now little Johnny is 5 and he's getting ready to go off to kindergarten for the first time and step into a different environment. He doesn't really have the tools at this point to emotionally regulate himself particularly well. He's a little bit reactive. He doesn't have access to healthy foods. He has people who are in his home until very late at night. He's not able to get sleep, and he's really struggling just at even in kindergarten to be successful. Now, as we follow him through, as he gets older into 2nd grade, he starts to fall behind in some of his schoolwork, struggling still to regulate those emotions. He's having angry outbursts. He's maybe been suspended once or twice. And he starts to get this reputation at the school for being kind of a troubled kid. And as he continues to progress through middle school and high school, that reputation follows him and he starts to believe it on his own. So he's still behind in school. He's still struggling in this area. He starts to believe he's a bad kid. His life is pretty unstable. He's very unhappy. And someone introduces him to drugs. And for the first time in his life, he feels accepted. He feels like he has a group of people around him that will take care of him, no matter what the situations are, who have his back, who are ready to protect him. And he starts to feel good about things in the world. And that starts to create a relationship with substances that is really negative. It can develop into dependency or addiction, but it follows him into adulthood. And now he's really struggling to retain meaningful work. And maybe he has children of his own, and he's struggling with the stresses of supporting that family. Very likely that he's interacted with the criminal justice system once or twice at this point, and you can start to see how all of these factors just sort of start to stack up, and he starts to develop issues around hypertension because he's drinking too much. Maybe he had a family member who had diabetes, and he's developed early diabetes because he didn't have access to great food growing up, and again, because he's drinking a lot of alcohol. So these are all some of the things that they found as they looked at individuals who had these adverse child events, that what they found was really terrifying, actually. So individuals with 4 or more ACEs had 240% greater risk of contracting hepatitis. Little Johnny is 390% more likely to develop COPD because he's twice as likely to be a smoker. 240% higher risk of contracting a sexually transmitted disease. He's 12 times more likely to have tried to attempt suicide, 7 times more likely to be an alcoholic, and 10 times more likely to have injected street drugs. And so it really becomes important in the context of the work that we do and for other healthcare providers to understand the ACE study and how these childhood factors, which aren't necessarily something that you're going to be talking about when an individual is 30 and sitting in your exam room, are really having an impact on their ability to interact with the healthcare system and to manage some of those chronic diseases or deal with the things that you're asking them to do in terms of being compliant with the treatment plan. So we talk about this a lot at the clinic. We really want to be a trauma-informed organization. We want to be able to acknowledge that that trauma is present without necessarily having to know what the trauma was, but letting that knowledge that it is present guide our interactions with the patient. So we had a wonderful speaker who came and talked to us, I think back in February, just before things got pretty crazy, as a peer or somebody who had lived experience in this area. And she tells this really amazing story of going in to have a women's health exam, and kind of the intern or the resident who was in charge of that exam coming in and saying some stuff to her. He had his back to her the whole time, didn't introduce himself, and she just immediately shut down. She didn't want to do the exam. She was done with the whole situation. And so I think it's really important for us as healthcare providers to understand, particularly in the homeless community, that this is a huge part of the population that is walking through the door and seeking services at the clinic. And that if we're not able to guide our practice in this way, we're not going to see returns to the clinic. We're not going to be able to provide ongoing continuity of care. So when we look at ACEs with regards to individuals who are homeless, 66% of those individuals have an ACE score of 5 or more. For us in clinic, we do an ACEs screen every time an individual comes into clinic, and we find that our ACE scores range between 4 and 9. So we know we have a large group of individuals here who have a lot of things that are going on from their past that are guiding their interaction with the healthcare system today. Large numbers that disclose mental health diagnosis and learning disabilities, and high rates of members who are incarcerated, homeless individuals, individuals with serious persistent mental illness, on average died 25 years earlier than the general population. They are more likely to have lived with somebody who has used street drugs, and they're more likely to have experienced physical abuse. And so our goal at clinic is to really be able to create a holistic, safe environment for an individual to come in and access those services. So what is 4th Street Clinic? We were established as a small, so we started out in 1988 as a single exam room at the Road Home with a partnership with some of the local hospitals to provide some care outside of the hospital system. In the mid-90s, we became a 501c3, and we moved into our current location, which is on 400 West and 400 South. And then in the early 2000s, we became a federally qualified community health center. So the FQHC program is a nationwide program that allows organizations like ours to access federal funds in order to help provide comprehensive primary care services for low-income individuals, regardless of their insurance status. So we've been an FQHC since 2001. That program accounts for almost 40% of our operating budget, so that's a really big deal for us. The FQHC program is kind of broken into a couple of different pieces. So there's just the traditional FQHC program, and then there are ones for special populations, and we're one of the 295 in the country that are dedicated to serving only homeless individuals, so we're a special population clinic. We do accept all forms of health insurance, Medicaid, Medicare, and other forms, but we also don't allow that to be a barrier to care. And so we're able to offer services on a sliding fee scale based off of an individual's income. So for individuals at our clinic, it's going to vary for every health center, but for individuals at our clinic, if you make less than 100% of the federal poverty, threshold, then there's no fee associated with you coming into clinic and seeking services. And then from there, it goes from $1 up to $4. So we try and set that very reasonably, understanding that our population is homeless and they have limited access to funds. We have a whole host of services that are available at the clinic. And again, this really gets back to our philosophy around whole health and wanting to be able to provide as many services as we can on site. So of course we have primary care, dental, behavioral health. We also have an on-site pharmacy who's able to fill prescriptions for those individuals who have Medicaid and for individuals who are uninsured. Access to medication is a huge barrier for health outcomes for individuals who are uninsured. So we're really pleased to be able to offer that pharmacy service. We're working on an integrated care model, and we're really starting to link up behavioral health and primary care more and more, because we recognize that those things really truly are quite intertwined with one another. And so we now work with a model where the primary care provider will go in and have a visit with the patient, and then immediately following that visit, a behavioral health consultant will come in and talk to the patient as well. And that consultant, BH consultant, and primary care provider are able to then develop a care plan in unison with one another, and follow that for continuity. And oftentimes what we find is that, for some of our population who are coming in, who we do know have mental health or substance use disorders, they're not ready to talk about those things yet. They're not ready to engage in those, but they're willing to talk about something like, say, for example, their uncontrolled diabetes or their hypertension. And maybe they come up with a plan with their BH consultant as a part of trying to control their diabetes. That includes scaling back, say, from drinking a 24-pack to drinking an 18-pack a day, right? And so we're able to set these very small, achievable goals and working with the patient to help improve health outcomes. Prior to COVID, we had specialty care services that were offered through volunteers that were coming on site. We're starting to ramp those back up again, but there's a large disruption in our services as a result of the current pandemic. We also offered wellness classes, and those have been scaled back substantially. We have an on-site lab, so we're able to do a lot of lab processing on our own. We do Medicaid enrollment, care coordination, case management. We offer respite care, which is for an individual who maybe is transitioning out of the hospital. Maybe they have had a surgery and they're being discharged, but it's not a great idea for them to go back onto the street or even necessarily to go to the shelter. So we're able to put those individuals into a motel so they can have that additional time to recover. We work with VOA to bring meals into them while they're in the motels. And then we have a medical street outreach team that has a provider and a medical assistant who are able to go out into the motels and do that follow-up care and make sure that individuals are progressing like they would. And then just navigating the system, referrals and other diagnostic stuff as needed. So when Salt Lake County decided that it wanted to revamp the current shelter model, or I guess the old shelter model, we have a new shelter model now. It's been in place since about the end of 2019. We had to come to the table with lots of other community partners to figure out what was going to be the best way to provide services, given that the main shelter, which was located about a block and a half away from us, was scheduled to close, and individuals were going to be moving all over the valley. We also heard from service providers that they wanted nurse care management services, or they wanted healthcare, primary care on site. Their staff were being hit with constant issues around healthcare, and so we developed our nurse care management model, which basically takes nurses and places them out into the field where we can have them do some triage, some basic medical care, med management, and coordinate services in clinic. Following that, we had our mobile healthcare program, and that was staffed by a medical assistant and a provider. So that kind of dovetails off nurse care management, where we go to fixed sites. It's a 3-room exam room. We can do primary care. It's basically like you would interact with your healthcare provider, only it's on a mobile clinic. And before we go to Q&A, I just want to talk a little bit about how COVID has changed how we do things. So the majority of our patients now are seen in medical tents that we've constructed in our back parking lot with partnerships with the city and the county. That's to ensure patient and staff safety. Those nurses that we just talked about, we've had to pull them back into clinic because we basically operate an outside clinic and an indoor clinic. And so they've been redeployed back into clinic to support that. One of the positive things that's come from COVID is telehealth, and then mobile has really been redeployed to do testing on site. So the mobile team goes out 4 days a week. They do testing at different service locations. As a goal for us is really to try and identify cases early and shut them down before they can really do a lot of damage in the shelter system. And I'm going to try to show you this video, maybe. I'm going to stop sharing, of what it looks like in our tents, because I think it's pretty, we describe it a lot, but it's pretty cool to see. So it's short, Ben. I know you want to go to Q&As. I don't know where it went. Can you see that? I'm guessing that's a no.
I can see it.
Oh, you can see it. Oh, okay.
See it, yeah.
Great. Now it's gone.
Sorry.
No, it's okay. I don't know what I did. Video folders. Oh, goodness. It's easy to find. Okay, let's try this again. Okay. So this is our current clinic operations. We have relocated our front door into the back parking lot, and so so all of our patients go here to check in and then to be screened to come into clinic. They're met by a screener who is typically a volunteer. Sometimes we have a staff member who's able to be out there as well. They ask them a series of questions, what they're coming into clinic for, do the typical screening things, and they are then either escorted around the front of clinic or they come in here, which is our new triage and front desk space. Inside here, we have triage nurses, enrollment for Medicaid, front desk, individuals checking in, picking up prescriptions. Once they're done in here, they can either wait in that round tent back there or outside. Most people prefer to wait outside. And then these are our new exam rooms. We have behavioral health and primary care, both working outside right now. And we continue to try and do that integrated model. So we've set up inside here kind of these makeshift exam rooms, as you can see, where you can have space for a counseling session or where you can have your medical visit with your provider and be seen for whatever medical need you came in for. This is our respiratory tent where we're seeing most of our COVID patients and other individuals who have respiratory issues going on. And then our provider tent here where we have a full team. So that's a therapist, a case manager, we have a doctor there in the background, medical assistant. We have our lab cart so that we're able to do lab draws, our COVID lab point of care testing set up in here, and a care coordinator. And so our staff have been outside since March, working in all kinds of conditions. Hot weather, cold weather, rain, snow. And so I just mostly say that to give you a sense as to kind of what's going on now with the pandemic and how amazing they are, because it has not been easy. So that's all I had prepared for you, and I'm happy to take questions.
Awesome. So we can